very wonderful presentations. Thank you, Margaret Rogers from ASHA. The depth of knowledge and practice, experience that the clinicians need to have with both of the approaches that were presented from LEAP as well as from LIDCOM suggests to me that as we move forward, there's going to be increased need for specialization, at least within our speech-language pathology and probably audiology fields, and wonder if you might speak to what sort of training models you see at a macro level that will be required to move, to scale up these approaches to the level that I think you're both doing and envisioning.
Yeah, just off the top of my head, I mean, it seems like the LIDCOM folks in Australia and those of us who are in the consortium have been doing training all over the world for about, I don't know, 10 years. And so we're sort of used to developing workshops and using the same visual stimuli and having the same format of the workshops all over the world, and then following up with support. So, so I'm probably not thinking through this clearly, but I don't really see a need for big changes in what we're doing now for training people in the LIDCOM. How do you feel about that, Phil?
Well, I think at the early childhood level, there's been a fair amount of research within in-service context regarding practices that really change people's behavior with clients. And I think the simple answer is there has to be practice-based coaching, but what I see as the primary limitation is that people spend their time and energy figuring out who the coaches should be, what the coaching paradigm should look like, what the coaching content should be. Those are all legitimate, but there's another party in this dance, and you have to be equally concerned with creating the conditions under which people can be coached, right? So sometimes that involves getting substitutes, sometimes that involves different sort of reimbursement schemes that have to be put in place. There's just not free time, if you will, in people's schedule to receive coaching. And I think that's in our work outside of the autism field, that's our biggest challenge, to figure out how to help people think about the mechanisms to free practitioners up such that they can access coaching.
Great, thank you.
And that answer is idiosyncratic. You know, it depends upon the circumstance, the organization, the financial structures, the states that you're in, and I don't think there's one. I can't give a response. I wish I could. Yeah.
Well, my question actually follows closely on what you were just saying, because I was curious about that one little datum in your one slide that you did reference, and talking about the noise in the real world as we've been talking throughout this summit. There was that one where they didn't get the coaching, they didn't get the piece that was the active ingredient, and yet there was that 96% fidelity. So I was just curious what you think went on there, and what I mean, it's like hopeful, oh, maybe there's some way to just ship out some handbooks, and, you know. So just curious what you think happened.
Well, that's a really good question. So that was an N of 1, where that only happened in one classroom. And I don't know. I will say this, just coincidentally, the lead teacher in that classroom received a national award as the best teacher in the world.
That explains a lot.
And yeah, we did that wasn't planned when the random assignment was made. But I think, what can you say? There are extraordinary human beings in the world, and with minimal exposure to information, they take stuff and run. But I don't think that that's anything but a rare exception. And I don't know how, I don't think you can, I can't think of how you create the circumstance to get things for free. Because as I look at changing adult behavior, I see very little data that you get things for free. You have to work at it, just like you have to work at changing kid behavior. And sometimes it's actually more difficult because you have fewer contingencies in the situation. Pardon me?
Then you have a less plastic brain.
I was going to say, and less plastic toys, too.
Sorry, just a comment about that. If you've read the work of Atul Gawande, you see that he talks in Public Health about looking at positive deviants. And he's got a book called Better, in which they talk about a cystic fibrosis program that had just exceptional rates of lifespan in kids. They just had dramatically longer lifespans, and something like a study that examined that individual case might be a positive deviant study that would sort of let you see how you might find what those characteristics were to help you optimize it.
No, that's a, you know, that's a good point, and you know, it makes me think about the limitations of fidelity measure. And I made a snide comment about an F word, and I didn't fill in the rest of the paragraph, and that is, there's a difference between getting to fidelity and becoming fluent. And here's the distinction. People who are fluent, when asked, will say, I don't need your help anymore. And they will become assets and resources to their colleagues. That's another indication of fluency. And I think that's probably what happened in that one, if you will, outlier classroom. You have a person who's extraordinarily gifted clinician, and he took it to that other level. We learned an important lesson about this through actually our parent training intervention. So it takes us a relatively short period of time to train parents to do new behaviors with their kids. And they have, relatively speaking, fast effects. But if you ask parents, are you comfortable doing this routine, they'll tell you no. They'll tell you no long after their behavior has changed and their child behavior has changed. They're waiting for the shoe to drop. And I think a lot of folks in your field, when exposed to a new intervention, are also waiting for that shoe to drop. That, okay, it worked with 2 kids, but why is it going to work with the next person who walks through the door? And, you know, for me, the implication is how long you hang with people in the replication process, and that you can't just think about supporting their behavior change. Often you have to think about supporting their cognitions, supporting their feelings about themselves as practitioners who've been asked to change things dramatically, perhaps, from what they have been doing for long periods of time.
Okay, thank you very much to Dr. Guitar and Dr. Strain for their perspective on some preschool intervention involving different contexts and including families. So if you could take just a 10-minute break and be back here at about 10 after 3. See, that was fantastic. Okay, we have, we're changing our breakout sessions a little bit, and Pam will talk to you about that, but we're going to give you about 10 minutes to ask questions of our 2 wonderful exemplars in Parkinson's and universal newborn hearing screening.
Hi, I'm Kathy Binger from the University of New Mexico, and if the other 2 speakers are here from this afternoon, this question is really for all 4 people. I'm wondering, based on either what you've learned in the last couple of days or what you've learned in the last couple of years, depending on where your knowledge base is with implementation science, if you were starting your programs over again today from scratch, with an implementation hat on, and looking at the long-term dissemination, we've talked a lot about the scaling up and those aspects of things, but there are also lots of things I've been learning that we need to be, if we can, think about when we're getting started with our programs. So what advice would you have in terms of things that you would either do differently in your program starting again and or advise other people who are getting started with these kinds of programs?
Great question. I mean, that is really the question, isn't it, of the hour. Well, I believe in, I'll say a few things because there's a lot to say. I believe in the concept of participatory action research, but I think had we put a lot of time into that before we developed our treatment, we may have watered down what has ended up being some of the more key core kernels of our treatment. So I believe that it's a combination of those things. I think you listen to clinicians, you listen to patients, and you always are driven to make the highest quality outcomes you can. And we would still use our physiologic logic and base and understanding of Parkinson's to design a treatment that had the best outcomes. But I feel more tuned into the significance of that attribute, certainly. There's probably more I can say, but that's all my brain can think of at the moment.
Yeah, I wish that we had had more, were better able to define what the intervention actually is. But in deafness, it's such a big problem because is it the counseling procedure? Is it the fact that parents are less stressed now? Is it the fact that the interventionists have higher expectations? Is it the fact that, what we're doing in auditory skill development or semantics or pragmatics or phonology or voice or all of the things that I can't tell you why the early intervention program is working. I can tell you that it is working, and I can't take away something just to find out if it's going to crash the system, right? I mean, is it necessary to have all the components that we have? I have no idea. All I know is that the whole package works, and that's not, how replicable is the package? That's another question. Mm-hmm. So if I could turn back the clock, I think I would not have gone in as many zigzags, because if I had heard all the talks from yesterday, I would have known what I was doing instead of having to discover it along the way.
Yeah.
Barry Guitar, University of Vermont. I just wanted to make one comment. What I would do differently? I mean, without a doubt, I would start kind of to disseminate from the get-go. I mean, as I said, we started this in the year 2000, and our focus was on getting supervised grad students to do the LIDCOM program. Well, we would have started. If I had to do it again, I would have started immediately, also adding to that SLPs and early intervention, and then we would have been able to start the adaptation process earlier. What do they need? How do we need to change it?
Hi, I'm Priya Kacharia. I will be starting my doctoral program at the University of Oregon in September. Right now I'm a clinician working at a skilled nursing facility. I was LSVD Loud certified, just got my certification, and yes, I do swear by your program, amen. And the effectiveness is amazing. But listening to the talks and sessions from the past 2 days, my question is sort of directed toward the adaptation and sustainability piece. I work in an environment which is very strongly determined by Medicare and RUG levels, and oftentimes the treatment fidelity is impacted greatly. I think there have been very few times where I could stick to treatment sessions that are an hour long for 4 weeks. I mean, I'm lucky to get 45 minutes. I feel blessed on the days that I get 45 minutes for speech. So I know there have been like modified LSVT programs, but it doesn't always fit our environment with the frequency and dosage that sometimes we don't get to determine as speech therapists. And so that was part of my adaptation question is, I know you're constantly experimenting with LSVT, but I'm not sure if I'm interpreting this right. A good chunk of our aging population is in skilled nursing facilities. We get a good proportion of patients as well with Parkinson's that are on Medicare. And sometimes I want to adopt this technique, but I'm challenged because I may only have them for 2 weeks. Then they move on to home health. Our home health team is different. I'm an in-house speech therapist, and I cannot follow this patient. So all I can do is recommend on the discharge summary saying, yes, I do recommend that you follow up with the LSVT Loud program, do it with a certified clinician, but that's all I'm able to do. So if you could talk to that sort of, that piece of the implementation and how it relates to.
Absolutely. It's an absolutely critical question, and we get it constantly. And when we train speech clinicians, it's one of the most common things for us to address. And so I'll try to answer it at a few levels, and I won't say I have the answer, but I feel like we must address it. One is for us to address it at a higher level in terms of reimbursement and the data we have to drive the ability to get reimbursement that you would need to be able to continue to do that. And that is something very high on our priority list, and probably in answer to the first person's question, one of the things that I wish we would have had the bandwidth to pay attention to earlier in this process. How is it that certain medical interventions that we know are reimbursed easily and behavioral treatment with a depth of data are not? And if someone could show me the path, I'm on it right now. So that's one piece of the answer. I feel your pain. Number two, sometimes we will say to clinicians in your circumstance, identify your home health providers who you can simply refer the patient to get the whole program once they leave your facility. If you only have them for 2 weeks, it may be you can do a little introduction to them, get them going, but you really want them to get that intensive dosage of the intervention. And we have said, in fact, we were just at Burke Rehab outside of New York City, and that is something they have done. They have an inpatient clinic where they can see patients for the entire program, but then they have they have the outpatient clinic where they can see the patients for the full dosage, and then the inpatient clinic, the clinician orients the family and the patient and then makes the referral for the home health clinician who can actually deliver the dosage. The other thing is the LSVT companion software, depending upon the patient, if you have the ability to get the patient engaged in that software, they're able to continue to practice. And it's not billable as a session, but it allows them to keep that intensive exercise going. So we're on it. We're doing the best we can, and I'd love for anyone to give us a path to reimbursement. We're on it. We're going to do our best to make that happen. Thank you.